check. So next we have Michael Mack, MD, FRCPC, FCPA, is a sleep medicine specialist and an assistant professor, Department of Psychiatry, University of Toronto, adjunct research professor, Department of Psychiatry, Western University, and adjunct clinical professor, Department of Medicine, McMaster University. He is the director of undergraduate education at the Center for Addiction and Mental Health and the Transition to Practice Coordinator and the Program Director for the Sleep Medicine Fellowship for the Department of Psychiatry at the University of Toronto. He serves on the education committees of the American Academy of Sleep Medicine and Canadian Psychiatric Association.
You can hear me, right? Yeah. So today I'm going to talk about a topic that I'm very interested in, which is insomnia and how to improve your sleep. These are my disclosures, and I won't be talking about medications in this talk, so they won't apply. In terms of our objectives today, first off, before we talk about how to improve a problem such as insomnia, we have to define it, and we have to talk about how we're going to assess for it, how to make a diagnosis properly. And then subsequently, we're going to talk about some behavioral treatments, non-medication treatments that we can use to improve our sleep and hopefully improve sleep for everybody. But I hope that my talk won't put you to sleep today. So first off, we're going to define insomnia and show you some statistics, show you some epidemiology, and how to assess for this issue. So first off, insomnia disorder has to have some sort of nighttime problem. Either a problem falling asleep, staying asleep, or waking up too early. And of course, a disorder is not a disorder if it doesn't cause you some sort of daytime dysfunction. And lastly, there's a duration criteria. The symptoms have to occur at least 3 times a week for 3 months. When we think about insomnia disorder, it is the most common sleep complaint in the general population. It's often comorbid with medical and psychiatric illness. And we know that it follows a chronic course when we look at work that's been done by Charles Morin, looking at the natural progression of insomnia disorder. It doesn't seem like it's something that will just go away on its own. And of course, if a person meets criteria for insomnia disorder after 12 months without treatment, it appears that at least 74% will still meet criteria for this issue. And lastly, we know that it exerts a significant functional and quality of life sequelae. Now, what about epidemiology? If we're thinking about the nighttime symptoms, a problem falling asleep, staying asleep, or waking up too early, that's about 30% of folks at any given time. Furthermore, if we add to that a daytime impairment criteria, your nighttime issues now cause you some daytime problems, that's 10 to 15% of all people. Furthermore, if we add the duration criteria, 3 times a week of having the symptoms for 3 months straight, you're looking at 6 to 10%. And I want to point out that insomnia disorder disproportionately affects female gender. This is a paper that was released quite recently in 2022, featuring the brain trust of insomnia researchers in Canada worldwide, looking at the costs to society from insomnia. So two different types of costs. Direct costs. How much are we paying doctors to see patients with insomnia disorder? How much are patients paying for therapy and medications to treat their symptoms? Those are the direct costs. Indirect costs include things like presenteeism. If the person suffering from insomnia shows up to work, they did their best, even though they were kind of drowsy, they still went to work. Their productivity is not as good as it would be should they have not had insomnia. So that's presenteeism. And of course, there's absenteeism, where the symptoms of insomnia have affected the person so badly that they can't even get to work. So if you add those two costs together, this study estimates that it affects Canada by the way of $1.9 billion yearly. So I submit that insomnia disorder is a significant public health issue and deserves more attention. This slide just shows you that there's a bidirectional relationship between mental health challenges and symptoms and insomnia disorder and vice versa. If you have poor sleep, you're more likely to have bad mood and bad anxiety, and the other way around. And we know that insomnia is associated with many medical illnesses. And on this slide here on the left-hand side, you can see the full gamut of medical illnesses, ranging from things like heart disease, cancer, hypertension, to gastrointestinal problems and pain. And if you have any sort of medical problem listed here, you can see that your odds of having insomnia disorder goes way up. So how do we diagnose this problem now that we understand what it means to have insomnia? You can take a good sleep history, which means asking good questions about a person's sleep habits. When do you fall asleep? How long does it take for you to fall asleep on average? Do you wake up in the middle of the night? And why? And for how long? And how many times? And what time do you get up for the final time in the day? And is your wake time different from Monday to Friday versus the weekend? Because we often see that that's the case. And do you take daytime naps? These are all factors that can affect a person's nighttime sleep. Of course, we can ask a person to track their sleep serially by asking them to fill in sleep-wake diaries. And I'm going to show you some examples of what a sleep-wake diary looks like. And of course, we can leverage technology meaning actigraphy. So that's sort of like a research grade way to measure someone's sleep onset and offset, looking at a person's movements. The idea being that if a person is moving quite a bit, they're probably awake, and a relative absence of movement being sleep. So that way a person could just go to sleep and wake up, and we still have a recording as to when they went to bed and when they woke up. And we always reserve the right to proceed with a sleep study, a polysomnography, where we measure the person's brain waves and look at their chin movements to see if they grind their teeth, if they have sleep breathing disorders like sleep apnea, tracking their heart rhythms the entire night, because so many sleep issues do affect the heart, and ruling out things like restless legs and sleepwalking and sleep talking. If you have a symptom of a physical sleep disorder, we might do a sleep test just to rule that out, because sometimes those conditions can also affect whether you have insomnia or not. These are two examples of sleep diaries, and the one on the left-hand side is the one from the American Academy of Sleep Medicine. It's more of a visual approach. Each square represents 1 hour of sleep, and if you did fall asleep, you would fill it in with a pencil or a pen. And of course, if you've taken medications, you write an M. If you're consuming caffeine, you're down a C. If you're exercising, you put down E. If you have any sort of alcohol, you put down an A. On the right-hand side, we have a more numbers-based approach. This is what's called the consensus sleep diary, whose development was led by Professor Colleen Carney at the Toronto Metropolitan University. So, different ways to approach the same issue, which is defining when a person sleeps, what their sleep habits are like, and when they wake up. This is just a slide that shows you what an actigraphy device looks like. And of course, these actigraphy devices we use for research purposes, but there's a lot of trickle down to consumer grade sleep trackers and fitness trackers. So when you think about things like the Apple iWatch, Garmin and Fitbit sleep trackers, they are all using the same idea, which is they measure movements in the 6 axes: up, down, left and right, and front and back. With the idea being that if we're trying to fall asleep, or if we are actually asleep, we're probably not moving very much. And when we're awake during the daytime, I will be moving, and we measure these movements, and we plot it on sheets of paper on your computer screen, as you can see here on this slide. The black bars represent periods of relative increased movements, and the teal or blue horizontal bars represent periods of relative lack of movement. So we like to think that the blue bars represent the times when a person might be asleep. And in this example, you can see that on day one, the person seems to fall asleep, just after 10 p.m. here. This is 8 p.m., this is 6 a.m. But on day 3 and 4, the output shows no sleep during the periods of time when the sun is down, presumably. So this might be the actigraphy output of a person that has insomnia disorder. And I've talked about how there's this trickle down of this technology. Lots of people wear smart devices that track their sleep. And the question that comes up quite often is, are those devices accurate? And the answer is, they're quite accurate when it comes to assessing when a person fell asleep and when they woke up for the final time, and maybe middle of night awakenings. But the thing about these devices is that they're not accurate when it comes to sleep staging. So sometimes folks will have one of these devices, and on their apps attached to their phones, it might tell you that you had 75% light sleep, and you had 10% deep sleep, and the rest of it was dream sleep. The problem with that is that it's completely inaccurate, because it's trying to use movement as a means to stage sleep. And while you can do that to some extent, it's not accurate unless you can take it by measuring brain waves, which we know that these devices don't do that. So they also have a tendency to overestimate your total sleep time and underestimate the time that you're up in the middle of the night or during any point in the night when you're still awake trying to fall back asleep. And the reason is this: if you're trying to fall asleep again in the middle of the night, you're probably not moving very much. So you're going to be pretty still, and that fools the device into thinking that you're actually asleep. So it overestimates your sleep time, underestimates the time that you're actually awake in the middle of the night trying to fall asleep again. So in summary, insomnia is a widespread problem. It's associated with many comorbidities, whether it's physical ailments or mental health challenges. And we know that we can assess it by asking good questions, using sleep diaries, or leveraging technology. So moving on to what I feel is the more important part of the talk, tips to minimize insomnia and some non-medication treatments to consider. And on this very first slide, you can see that I've shown a diagram here of CBTI, which we know is the absolute best treatment for insomnia disorder. It's the first line treatment. It's the best that's out there. So we've studied it quite a bit, and we know that it is very effective in treating insomnia symptoms. It probably has an equal effect as any sleeping pill in existence. But the added benefit of doing this therapy is that when you complete the course of the therapy and your insomnia symptoms improve, they have a tendency not to come back, which is not the case when you take medications. Medications are sort of low effort. You take it and it might kick in, you might sleep well, but you take the pill away and you might not have good sleep afterwards. So that's the issue with medications versus therapy. And we know that when people take cognitive behavioral therapy for insomnia, it gives them a chance to come off of sleeping medications, of which many carry significant side effects. And if we're thinking about things like benzodiazepines or Z drugs like Zopiclone and Zolpidem, and these are just common sleeping medications that doctors prescribe, we know that if folks take them on a long term, that they can develop addiction and tolerance. Your body gets used to the effect of these medications. If you've been taking them every night for, let's say, 2 or 3 weeks in a row, and you stop taking them, you can get what's called rebound insomnia. Your insomnia symptoms on the nights that you stop taking it might be a lot worse than what you already came in with before you took the medication. Moreover, we know that sleeping pills can increase your risk of falls, and in older folks, that might increase your risk of hip fractures, and we don't want people to catch that. Lastly, cognitive behavioral therapy for insomnia has been shown to have significant antidepressant effect, independent of its effects on sleep. So not only does it improve your nighttime sleep, we know that it is an effective treatment for depression. And that's actually been shown by studies done by some of the delegates that came here to the Canadian Sleep Society meeting this very week. So what does cognitive behavioral therapy for insomnia look like? Well, it has 5 components. It consists of sleep restriction, stimulus control, relaxation-based interventions, cognitive restructuring, and sleep hygiene education. And as an educator myself, I just want to point out one thing is that basic sleep hygiene in and of its own, in isolation of all the other components of cognitive behavioral therapy for insomnia, that hasn't been shown to be effective in treating a person that meets the full criteria for insomnia disorder. So if you're dealing with a patient that has had problems falling asleep or staying asleep or waking up too early, and you've had this for three times a week for 3 months, and it's causing you a daytime issue, just giving them a sleep hygiene talk isn't necessarily going to improve things. And the way I think of it is most people with good sleep will likely have good sleep hygiene, but just because you develop good sleep hygiene doesn't mean you're going to have good sleep. So there's different ways to get this therapy. So the classic way is to give and receive it on a one-on-one format, classic therapy. And of course, with all therapies, we're looking for ways to expand our reach. Therapy that's given one-on-one is limited by access. There's only so many therapists that are out there. So we know that cognitive behavioral therapy for insomnia is also effective if given in a group-based format. There's evidence that shows that if it's done through an app or the internet, then that's also effective. And of course, brief formats, simplifying things to make it easier. As with anything in life that's good, there's a bit of bad that comes with the good. You might not want to do this kind of therapy on patients with a history of seizure disorders. You might have to be careful about that, because if you restrict a person's sleep and they have a history of seizure disorders, they might be at greater risk of having another seizure. And you have to be careful of giving this therapy to people with bipolar disorder for the reason, if you restrict a person, if a person with bipolar disorder and they have their sleep restricted, we're reducing the amount of time that they're allowed to be sleeping, that increases their chance of falling into mania, which is not what we want. And of course, certain older folks might be at greater risk of falls if we restrict their sleep at nighttime. So I talk about sleep restriction, and it's been known as probably one of the strongest components of what makes CBTI work for insomnia. What does it mean? So very simply put, we're reducing the amount of time that a person is allowed to spend in bed. And we're harnessing that natural wave of sleepiness that people will get the longer that they're staying up for. So it's axiomatic that a person that's stayed awake for 20 hours is sleepier than a person that's been only awake for 12 hours. And for those of us that do shift work or call at the hospital, this is something that we see quite often. The longer you're awake for, the sleepier you become. That's something called process S that I'm showing you here on this diagram. So if a person has insomnia disorder and I ask them to spend less time in bed and they have to be more active during the day, they're going to be sleepier as they hit their bedtime. Stimulus control, another principle of cognitive behavioral therapy for insomnia. This seeks to reverse the association of the bedroom and bedtime with the failure of initiation of sleep. So sleep is subject to the psychological concept of conditioning. And then, we understand the experiment of Pavlov's dog. This is a person who did an experiment feeding his pet dogs and at the same time ringing a bell. And then afterwards, after doing this for several days, if you just ring the bell and don't bring the food, the dogs are still expecting the meal, they're salivating. So sleep is something that is subject to conditioning. If you have bad sleep for a couple of nights in a row, unfortunately, that predicts worse sleep for the nights to come. And if we break that association between, going into bed and the bedtime with the failure of sleep, then the person might sleep better. The second thing here is that we want a person to have a sleep schedule that lines up with their internal body clock. So I think it makes sense for all of us that during the daytime hours, we naturally feel more alert. And as the sun goes down and we hit that 7 or 8 p.m. Time, then we all feel somewhat sleepier. So sort of putting together your sleep habits to line up with your internal body clock, but also with the light dark cycle of the external environment. So what are the tips for stimulus control? Wake up every day at the same time. If you have a consistent wake time, that also means that you have a consistent first time to light exposure. And we know that if you have the same wake time, that means that you have a stable internal body clock. And if you have a stable internal body clock, you have a better mood and better sleep at night. The second tip here is only go to bed when you're feeling sleepy. So while it's important to wake up every day at the same time, your bedtime can be different for the reason, depending on what you've done during the daytime, you might be more exhausted and liable to sleep earlier versus other days when you've been more relaxed, you might have to sleep a bit later. That natural wave of sleepiness might not come on later. So your nighttime bedtime can be different from day to day, but wake up every day at the same time. And the third point there says no naps during the day as a blanket rule. If you do nap during the daytime, that will subtract from your nighttime sleep. So we want to consolidate your nighttime sleep. We want you to have most of your sleep in the nighttime. So that's why it says no naps during the day. And of course, if you wake up in the middle of the night and you can't fall back asleep and it feels like it's been a long time, don't stay in bed. Get up out of bed, go to a different room and do something boring, like a word search. And when you feel that natural wave of sleepiness, which is that head nodding feeling that we all get if we're in a meeting for 45 minutes straight, that's your cue to go back to sleep. So what we're doing there is we're breaking the association of you being wide awake and being in your bed. And the last point there is use your bed only for sleep. Relaxation therapy is one component of cognitive behavioral therapy for insomnia. We're just sort of teaching folks how to reduce that sort of physical and mental stress and arousal that interferes with sleep. Sometimes folks will ruminate about things that worry them just as they fall asleep. If I tell a person not to think about anything that's stressful, then usually you'll just think of everything that's stressful. So you can't tell a person just to, clear your mind and relax. That's not going to work out. So we have specific techniques that you can try. So things like, closing your eyes and thinking about your favorite fruit, what the fruit looks like, the color, the texture of the skin, if there's any leaves. So these are mundane things that replace the stressful things that, can pop up in your head as you sleep that interfere with your ability to fall asleep. So there's also another way to do this is you can, sort of stress your muscles and just flex your muscles and then focus on what that feeling feels like and then relaxing and then feeling how relaxed your muscles are thereafter. So lots of different techniques. The whole point is we want you to be relaxed and not think about things that bother you. Cognitive therapy. So here we want to correct a person's faulty expectations and beliefs about sleep. I hear a lot of things like, if I don't sleep 8 hours a night, then I won't be able to work. And that's clearly not true. Some folks believe that if they don't get 8 hours of sleep, that somehow, their physical health will come at a great detriment. They might die from insomnia disorder, and we correct these faulty expectations. In the same way, some folks believe that they need 8 cups of water a day to stay hydrated. Well, if you did that, you might spend a third of your day in the washroom. Not everybody needs 8 hours of sleep. You just need the amount of sleep that you get, such that when you wake up, you feel good about yourself. So I've sort of talked about, some of these points here. The point is you can't blame bad sleep at nighttime for all the problems that you have during the day. And of course, sleep hygiene. And I think, we're all pretty familiar with these lifestyle environmental factors that make sleep conducive. They include points like, avoiding smoking cigarettes or nicotine use 2 to 3 hours before your bedtime. Same thing with the use of alcohol and caffeine. Avoid that for 2 to 3 hours before your bedtime. Exercise is great. It's great for your cardiovascular health. It's great for your mental health. And we'd like you to do it, but try not to do it just before you go to bedtime, just before you go to bed. Because if you do so, you're going to be amped up. Your heart's pumping harder and faster. So that's not conducive to sleep. And of course, keeping your sleeping quarters quiet, cool, and dark. and then keeping a regular sleep schedule. So there's all these complex components to this cognitive behavioral therapy for insomnia that I've told you about. And, it does take a bit of training, a bit of experimentation, for it to really kick in. We're always looking for ways to simplify things. And when we study the different components of cognitive behavioral therapy for insomnia, we know that the components that are most responsible for its treatment effect have to do with sleep restriction. So I'm just showing you a quick way to improve your own sleep should you develop insomnia symptoms. And it's going to be a simple way for us to do it. I think we can learn it in a couple of minutes. So this is a sample insomnia case that I've put here. So the person's bedtime is 12 midnight. They have a tendency to wake up at 8 a.m. the following day. So this person is in bed for 8 hours a night, but unfortunately it takes them 1 hour to fall asleep at the beginning of the night. So they have insomnia disorder. It takes them 1 hour to fall asleep. So they're only sleeping 7 hours. They're spending 8 hours in bed here. Okay, so how do we correct this? Now, I've told you that this person is spending 8 hours in bed, but it takes them 1 hour to fall asleep. So there's 1 hour of insomnia time. So if that's the situation with you, I would ask you to push your earliest to bedtime to the amount of to the same amount of time it takes for you to fall asleep. So if you have the insomnia, it's taking you 1 hour to fall asleep. You're going to spend 1 hour less in bed. So I'm not taking anything away from you. It's just that now you're spending 1 less hour in bed wide awake, and we're breaking that conditioning between being in bed and being wide awake. So if you do so, that's a form of sleep restriction. You're going to feel sleepier now as you try to go to bed at 1 a.m. And what we're going to do is every week, we're going to push your earliest to bedtime earlier by 15 minutes. So you went from going to bed at the earliest at 1 a.m. Now, the week after, you're going to go to bed at the earliest at 12:45 a.m. So this is a way for us to expand your sleep window slowly and allow you to maybe have a greater success in sleep. And you would just continue this pattern, expanding your sleep window by 15-minute increments every week until you're sleeping well again. So this is just a simple way to improve your sleep. We're restricting the time that you're in bed to harness that increased natural sleepiness that you might have to help you sleep at nighttime. I just want to put a plug for Dr. Armin Rahmani, who's one of our students, who's now at UBC doing a sleep medicine fellowship. He did a study, a scoping review, looking at different smartphone apps that deliver cognitive behavioral therapy for insomnia. Now, there's more than 360 of them if you look on Google App Store or Apple App Store. And most of them, unfortunately, aren't really backed by data. They're not backed by scientific studies. But he wanted to find which of the applications are backed by studies. And here are the list of the ones that are. And they include things like Sleep.io, CBTI Coach, Sleep Rate, Sleep Ninja, and Somnrest. So unfortunately, the last one there is actually out of commission. The one that might be most accessible for all of us is the one called CBTI Coach. For the reason, this application can be downloaded for free. Its development was subsidized by the Veterans Affairs Program in the United States. And it delivers sleep therapy that's backed by CBTI principles. So that might be a useful app for you guys to download and use should you develop insomnia symptoms. Some last ideas here. I saw this very interesting study looking at the use of weighted blankets to treat folks with insomnia disorder. And of course, if you're a parent, you've had the experience of swaddling your babies. And if you're a pet owner and a pet fancier like I am, I've done this to my cats. So for whatever reason, if you swaddle a baby or your favorite furry animal, they will relax a bit more. The idea here is that that sort of sensation of being covered causes some sort of proprioceptive activation of your nervous system, the parasympathetic nervous system, which is more relaxing. It's relaxing to the person, to the body, to the mind. So that's what we like to think how this works. So in this study, they looked at patients with comorbid mental health challenges, people with depression, people with anxiety and bipolar disorder and ADHD. What they did was they gave half these folks a weighted blanket, an 8-kilogram weighted blanket. The other half, the comparison group, got a blanket that was not heavy at all, but felt the same way. And they tracked their sleep over the course of 4 weeks. And they found that the people that got the weighted blankets slept a lot better. Their insomnia symptoms improved to a huge degree compared to the people that got the fake sham blankets. And after 4 weeks, all the people that used the sham blankets also got the active weighted blankets, and their sleep symptoms improved too. Their insomnia improved as well. And then, so that's for me, just a tremendous thing, because with the weighted blanket, it's really low effort. You just get the blanket and you sleep with it on. It's an easy intervention. This might be something that you might choose to try. Moreover, they also tracked how people's mood did in comparison between the weighted blanket group and the control group, and they found that the people that used the weighted blanket group, their depression and anxiety scores improved too. So maybe some potential here to assist patients with mental health challenges. So yellow sunglasses, amber sunglasses, we use these glasses to block the specific wavelength of light that your eyes will detect that tells your brain that it's the daytime. So we use amber sunglasses to treat patients with internal body clock issues, with jet lag. And this is just a small pilot study that shows that it might help people with straight insomnia, just a problem falling asleep or staying asleep. And these yellow amber sunglasses you can get on Amazon.ca for $5. It's a very, very cheap thing. And if it helps even a little bit, you know, it might be something that we might add to the tools in our toolbox to improve insomnia. So in summary, cognitive behavioral therapy for insomnia is the first line treatment. It's what we like to think to be the best treatment. And I showed you some ideas that don't involve medications that also might help insomnia disorder. And that's it. I'm happy to answer whatever questions you may have.
So we'll be opening up the floor to anyone who may have questions. There's a Q&A in the bottom of your screen on your Zoom call. Okay, so we've got one from Angelica here. Are there particularities to consider with an elderly population, given that they naturally have a decrease in sleep time?
So Angelica, that's a great question. And it's absolutely true. Like as you go down the age range, you know, there's a greater fragmentation of sleep. Your ability to initiate and sustain sleep decreases, such that in an older person, they might actually have a relative fewer number of sleep hours of sleep at night. And older folks sort of get around that by having more daytime naps. So it is true that as you go down the age range, especially if you hit the 65-year age mark, that people have decreased ability to initiate and sustain sleep. So for those folks, I would ask them to apply those cognitive behavioral therapy for insomnia principles, but I tell them that it's okay if they have to take a daytime nap.
Yeah.
Thank you so much for the talk. I have a question. I just want to clarify something. You spoke about relaxation technique in CBT. So you said that we have to think about something not stressful, not to stop thinking at all, right? Am I understanding you correctly?
Yeah, it's just really hard to tell a person not to think about anything. Like, you know, if you've seen Ghostbusters Part 1, you know, they told Dan Aykroyd, don't think of anything bad, because whatever you think that it's bad, it's going to turn into a monster. It's going to destroy New York City. And then he thought of the Stay Puft Marshmallow Man. Anyway, this is before your time. The point is that if I tell a person not to feel stressed, not to think about anything stressful, the mind, it's natural to wander off into things that are stressful anyway. So when we're using relaxation-based therapies, we're just trying to bring a person's attention to things that are mundane, that are, conducive to sleep, that don't stress them out. So oftentimes that means like, doing mindfulness exercises, looking at, mundane things in the bedroom, comparing how your muscles feel when they're contracted versus when they're relaxed.
Thank you. So we have a question. Can the recording of the presentation be watched afterward? Yes. So all of the presentations we've had on today will be posted on the Sleep On It website for your viewing if you didn't have a chance to watch the full presentation, or if maybe you joined us later in the afternoon. We have another question. So for elderly, if one wakes up after 3 to 5 hours to go to the bathroom, how can one address this issue?
Yeah, that's a great question. So we know that, as we go down the age range too, our propensity to have nocturia or use the washroom in the middle of the night does go up as well. If it's not related to a medical condition, then I would ask those folks to restrict their fluid intake closer to bedtime. So you can still stay, well hydrated, but I would want the person to bias their water intake to earlier in the day as opposed to closer to bedtime. So, maybe restricting fluids 4 to maybe even 5 hours before time to sleep. That will decrease your propensity to use the washroom in the middle of the night. In some cases, it can't be helped. If a person is taking diuretic medications, what we call water pills, that are used in the treatment of cardiovascular issues, sometimes those can't be helped.
Thank you. So I actually have a question. For those of us that wear glasses and also have a terrible habit of watching TV in bed or maybe scrolling on their phones late at night as kind of a way to decompress, do you find that like the blue light lenses are beneficial, or do they make any difference at all? Or is it just kind of a scam? I don't know.
I think the intention there is good. So like they're trying to block that blue wavelength light of 450 to 480 nanometers. And like, if we have exposure to that kind of light wavelength, then, that actually activates melanopsin receptors of our eyes that tell our brain that, hey, listen, it's daytime, so let's not secrete melatonin. Let's not go to sleep yet. The problem with the blue wavelength blocking clear glasses, is that when they've studied it, it doesn't seem to block enough of it, and that our eyes will still detect those wavelength lights, and the parts of our field of vision that are not blocked by the lens. So from that point of view, they're not very effective. Yeah.
So I have a question to piggyback off of that then. So I don't know about Android products, but for Apple products, I know that they do have a function where it's like a yellow filter on the screen. Would that make a difference, or is it kind of the same concept where it's just not enough?
I think, those are, we have to give them credit, to these technology companies for trying. Probably the best way forward is to avoid having any light exposure at all. I mean, even the fact that you have, exposure to light of a certain intensity, like let's not even talk about wavelength, that will also suppress your natural waves of sleepiness, your melatonin secretion. So if you want the best sleep, I would just avoid exposure to screens, LCD, iPads, etc.
Thank you very much. So I'll do a final call for any questions that our viewers may have. I don't see anything. No questions? No. Okay, awesome. Okay, so that brings us to the end of the public lectures of the Canadian Sleep Society's 11th National Conference. I would like to take a moment to thank our presenters today for sharing their knowledge with us. I'd also like to take a moment to thank our viewers for joining us, whether it was virtually or in person. It was an absolute pleasure to have you all. Once again, for those who may be wondering, our recordings of the presentations that we had today